Good afternoon. Thanks for joining us today. My name is Melinda Cooling, and I'm going to be sharing a little bit about OSF On Call, which is part of OSF Healthcare and designing new care models with digital health for pregnant women. So again, my name is Melinda Cooling. I serve in a couple roles within OSF Healthcare, including the Chief Clinician Executive for OSF On Call and the Senior Vice President for Advanced Practice. My distinguished colleague, Kara Rode, is with me today, and you'll be hearing from her in just a few minutes. I did want to share a little bit about OSF Healthcare in general. So we're an integrated healthcare system where our headquarters is in Peoria, Illinois. So basically the center area of Illinois. We're smack dab in the middle. However, we do serve across the state of Illinois, and we have one acute care hospital in Michigan as well. So amongst some of our locations, we have 15 acute care hospitals, with 5 of those being critical access, and more than 22,000 mission partners. And we call our employees mission partners because we really feel that they impact the mission that as we care for our patients on a daily basis. We also have 2 colleges of nursing associated with OSF Healthcare, and we have a network of primary care and specialist physicians across all of our ministry as well. So when we look at OSF Healthcare by the numbers, you can see on this map, it shows what we call our regions. So we have a Western, Central, and Eastern region. And within those areas, of course, we have ambulatory specialty practices. We also have acute care hospitals. Amongst our clinician group, we have about 747 advanced practice providers. That's APRNs and PAs that work amongst our regions and all of our different care areas. We also employ a little less than 1,200 physicians. To carry our mission forward, we have almost 23,000 mission partners that serve in a variety of roles, some of them clinical and some of them not. We do, as you can tell, a lot of multi-million outpatient visits. We do a lot of inpatient admissions across our acute care entity. And then we also have a really strong home health and hospice network that's embedded within OSF Healthcare as well. So to tell you a little bit about OSF On Call, we are a digital health entity inside of OSF Healthcare, and we always say that we've been very privileged and fortunate that our sisters and our board chose to invest in a digital health infrastructure to really help us provide care in new and innovative ways. And so OSF Healthcare is sort of the umbrella term in our branding for a full-scale digital health entity. And I'm going to talk to you about the 3 different divisions in a few minutes. But one thing that we really pride ourselves on is thinking about how our digital platforms, the software, really helps us support our patients and our communities 24/7. So all of the products that we build and develop are really centered around the patient and what they need, whether that come at 2 o'clock in the afternoon or 2 o'clock in the morning. We want to be able to provide those services. That may include video visits, it may include remote patient monitoring, and probably most importantly is the escalation to our clinical teams, which may include nurses, maybe advanced practice providers, and in some situations, physicians. We also have an urgent care platform that lives within OSF On Call that has bricks and mortar as well as digital services as well. So 2 really key things that we focus on is that we want to be here to connect with people 24/7, and then we want to be able to provide in-person, virtual, and home-based care throughout our entity. And a couple of the exciting things that we've started over the last year include the Hospital at Home project, as well as some of our telehospitalist work, which supports our services in our critical access center through a centralized model. So just to tell you a little bit about our different divisions. So if you think about digital experience, this is really the front end journey. So this is the way that we may outreach to patients. For example, some of the outreach that we have done in the past is related to cancer screening, encouraging patients to get that done in a much more effective and efficient way through outreach to the patients. It also is our contact center where we support 26 of our primary care practices for patients calling in through a centralized approach. So then the nurses and the clinical staff that are working inside of those practices can really focus the care delivery at that time to the patients that are sitting in front of them. It also includes the scheduling related to testing in our acute care hospitals, such as CTs or MRIs. And we're really working to standardize some of that workflow across our system as well to increase effectiveness. And then our digital care division, where is the work that we're going to talk about today lives. This is really related to a lot of the work that we do around remote patient monitoring. It's where our our digital hospital at home lives, as well as our telehospitalist, our EICU work, and all of the programs that really have to do with reaching out to a patient from a digital footprint. And our last division is related to what we call on-demand. And so on-demand has the services of a bricks and mortar urgent care where people work and play in our communities. So we strategically place these clinics for urgent type needs that patients need to try to get in and get out, and they are close to where patients work and play, so it makes it much easier for them to receive care there. But we also are able to add in the digital on-demand services for urgent care as well. So if it is 2 o'clock in the morning and maybe the bricks and mortar clinic is closed, you still have access to urgent care to make a decision about they can receive care right at that time with that clinician who's providing it, or it may mean that they need to be escalated into an emergency department if needed. So again, one of the big focuses of OSF On-Call is to make sure that we're there for our patients in their homes as much as possible, or where they feel like they can receive care 24 hours a day. So I'm going to turn it over to Kara to start the discussion about our Medicaid innovation work related to some of the prenatal work.
Thank you, Melinda. Again, I'm Kara Rote, the manager within the digital care space here within OSF On-Call. And before we really dive into the pregnancy and postpartum support program, I want to share with you kind of how this initiative got started. Just over a year ago, ourselves, OSF Healthcare, and 4 other federally qualified healthcare centers within the state of Illinois joined a collaborative to truly transform the way we care for Medicaid patients. So if you'll go to the next one for me, Melinda. Within this Medicaid Innovation Collaborative, we had to have structure. And so within that structure, to really reduce the healthcare disparities and improve health outcomes, we needed engagement, infrastructure, and digital clinical care. So within that engagement piece, we are really building engagement through continuous listening and feedback. We have built several new programs within the last year and know that in order to be successful, we have to hear the patient voice to know what they need or maybe don't need and make those changes accordingly. And then the flexibility and agility based on the neighborhoods and the communities that we're in to build that trust by always being available. From an infrastructure perspective, we have the technology platforms, integration, analytics, community health workers, and then mobile technology vans that really help us intertwine all of these pieces together to support our patients well. And then lastly, the digital clinical care space. So we, through this collaborative, have chronic disease management programs, digital wraparound services, digital behavioral health. What we're talking about today are pregnancy and postpartum support program, cancer screenings, and then integrated into all of it is virtual care 24/7, 365. So just thinking about the need for the change. So really when we thought about what we need to do in the Medicaid space and understanding what the landscape is for maternal outcomes in the United States and in the state of Illinois, just thinking about how women in the US are most likely to die when compared to 10 other developed countries. 17.4 women die per 100,000 live births. More than 4 out of 5 pregnancy deaths are preventable. That's from the IDPH. Black women are more likely to die from a pregnancy-related medical condition, and white women are more likely to die from a pregnancy-related mental health condition. And so really looked at some of the data that's out there, the outcomes that are out there, and built our structure around what's needed most to ensure that we're filling the gaps for the patient population that we had in mind. And so the virtual pregnancy and postpartum support program itself has many components. And so patients or women can be in our program from 8 weeks of pregnancy through 6 weeks postpartum. And any woman in the state of Illinois who has Medicaid is eligible for the service. They don't have to be within one of those 5 organizations that came together, truly looking to meet the need of all Medicaid women within our areas. And so throughout the program, patients will have access to education, 24/7 access to our nursing team and our provider team. We do blood pressure monitoring prenatally and postpartum for all of our women, virtual visits with providers, nurses, counseling services, lactation support, and really truly so much more. Within this space, we do use 7 different care plans because we want to ensure that we are meeting that patient where they are in their pregnancy journey. And so from the prenatal space, we have a first trimester, a second trimester, and third trimester care plan. And this really ensures that they're getting education and check-in questions related to their pregnancy where they are, as we know that the education and the needs change throughout that pregnancy journey. And then once they have the baby, we have 4 different postpartum care plans. And so we have vaginal delivery with and without infant care, and then C-section delivery with and without infant care. We know that not all women take home a baby when they leave the hospital, and this can be for a variety of reasons. So we just want to ensure that we are meeting that patient where they are with the care that they need, regardless of the outcome around what that labor was or their social circumstances that are encompassing them, to ensure that we're still caring for them in a way that's meaningful to that patient. So from the goals perspective, the goals of the virtual pregnancy and postpartum support program are to transform the healthcare delivery system for Medicaid beneficiaries in a distressed community. Add a layer of support for our clients that is person-centered, integrated, and equitable. And I just want to take this opportunity to point out that this program is completely in addition to the in-person or virtual prenatal services that they should be having or experiencing with their OB provider. This is supplemental to the services that they're receiving. To increase the number of pregnant women who receive timely prenatal care starting in the first trimester, measure and increase the number of women who will be screened for postpartum depression. We actually screen for depression and anxiety prenatally and postpartum. We're going to get a little bit more into that here in a few minutes. And then measure and increase the number of women who receive a social determinants of health assessment, and then further alignment with a team of digital health navigators who is really the experts in this work and align resources to patients very, very well. So from an outreach or an enrollment perspective, we kind of have 4 modalities of getting into our program. So one is community enrollment, and this really ties into the marketing piece too. They go together. So we have a lot of marketing materials that have a QR code, our phone number, our website listed where patients can go to self-enroll. And so those digital health navigators that I just touched on who live in our communities and help align social determinants of health also go out to community-based organizations, different clinics within the areas to tell individuals about the program and to help women get enrolled if they need the assistance. And then data-driven outreach. Any patient within our healthcare system who has Medicaid, who has been identified as pregnant, gets a phone call from our team offering them to join this free program. And we typically call women, like if they have a pregnancy appointment today, we typically are calling them within the next week to invite them to join our program. So pretty quick from the time you find out you're pregnant to the time that you hear from us to be able to enroll. And then, of course, provider referral. If a provider has a patient that they know could really benefit from this service, just giving the opportunity for providers to send referrals our way and enroll patients into our journey. Oh, Melinda, you're on mute. So next we'll talk about access. Melinda, feel free to jump in if you can get that mute undone. But from an access perspective, we have a clinical team that supports these patients 24/7, 365. It's nurses who staff our platform and are constantly watching for those chats that come in from patients, from the check-in questions that we receive, to really be able to answer that patient's question quite quickly and get them what is needed. And so they can interact with us via chat, so messaging back and forth, by phone call or by video visit. And then they get these check-in questions based on where they are in their pregnancy journey. And so when we think about those care plans that we discussed earlier, they are embedded with check-in questions that are very specific to that area of pregnancy that they're in, to ensure that we are checking for things that may pop up during that trimester, or things that we should be concerned about, to catch it early so they can get the care that they need quickly. The image below the words there is just a sample of what it looks like when a patient messages our clinical team. And so our test patient here had indicated that she has some symptoms that's concerning of a UTI. And so the nurse messaged her back and said, I'm concerned about you. I think we should get you a virtual visit with a provider. And they were able to schedule that virtual visit without even having to pick up the phone and make that accommodation for the patient. And then that provider then would later call the patient and either do a telephone visit or a video visit to meet that patient's needs, or to escalate them to the right level of care potentially. And then education. So this is a huge part of our program. The patient gets automated patient education, again, based on where they are in that journey. And so along the left-hand side here, you can kind of see some examples of what that education looks like. And it comes across as videos, articles, or written education. An example of that video is there towards the bottom of the screen. It's really easy for that patient to click play right within their feed of content and watch that educational video. And then the written education is also what you see here on the screen, very just easy to follow along and get the education that is needed. And then there's also articles that get linked out to the web. If somebody wants to learn more about the education that we're providing, there's additional resources that are available to patients. In addition to the educations that the patient gets within their within the app, we also host virtual weekly education groups. And we have two different series of these. One is just general pregnancy education groups, and the second is bi-weekly mental health support groups. And so within these weekly education groups, we do the same content month over month and continue to invite women to join. And so the first week of every month, we do normal signs in pregnancy. The second week, we do labor. The third week, newborn care. And then that last week of the month, breastfeeding. And then in the mental health space, we do these every other week, and we cover depression, anxiety, support system, and taking care of yourself. And I think when we think about the learning needs of patients and how that varies significantly across populations and just individuals as a whole, we want to make sure that we're meeting the needs of patients, or meeting them where they are. So by providing them videos, articles, written education, group education sessions, certainly time to get education from a nurse or a provider at any time, really opens the doors for various opportunities and learning styles to ensure that they are having their needs met, and then hopefully that's linking to better outcomes for patients. I would say too, with the virtual support groups, it's just a great opportunity for women to hear what other women are experiencing in their same stage of life, and know that it's okay to ask some of these questions, or hear the answers to questions that maybe they wouldn't want to answer or ask themselves. So it's been a great addition to the program that came post go live, but has been a great resource for patients and really for our team. So in addition to the access to the clinical team, to the education that they receive, the check-in questions, we have a couple other areas of support. So the first is lactation support. All of our nurses and providers came to us with OB experience, and so a lot of lactation consultants on our team, and actually also have a few ICBLCs who see our patients and do lactation visits with them, and do breastfeeding education, support women throughout their journey and their time of need, which has been just great and a very highly utilized resource within the program. The second is supplies. So every woman who joins our program, we help get them a blood pressure cuff. And we start asking about blood pressures within the second trimester of pregnancy all the way through postpartum. We know that the maternal hypertension crisis is significant, and so we want to do what we can to catch that early and get them the care that they need. Again, these blood pressures are in addition to the blood pressures that they should be having at their regular check-ins, but just keeping an additional eye on their blood pressures is valuable. And then some other supplies that we help women get are pumps, breast pumps, milk storage bags, prenatal and postpartum abdominal binders, compression stockings. So any supplies that would be helpful or valuable to a woman during the pregnancy and postpartum journey, we certainly help to align and have sent to their house so it's easy for them, comes right to where they are, and they have what they need. And then clinical counseling services. This has been a huge part of our program and a very much appreciated part of our program. Just having an additional resource for those who would like to meet with a counselor or who are feeling that they could use support in the space of mental health. It has been just a highly utilized resource to have the ability to do virtual counseling at any time. And our counselor typically sees a patient for 6 to 8 weeks to go through a program with the patient, and then certainly can continue to assist as needed. And then depression screening. So we do these depression screenings like we talked about early on within our goals. We do them at the beginning of the second trimester, the beginning of the third trimester, and then 2 times within the 6-week postpartum journey. The amount of women who have responded or who we have helped because of those screenings has been surprisingly higher, I think, than we had anticipated. And so we are glad that we're asking those questions and getting the women the care that they need at the right time. We have seen probably just as much depression and anxiety prenatal that we have postpartum. And so really being able to catch it early and support them through their pregnancy journey and thereafter is a great tool. Social determinant of health assessment and alignment. When women join our program, they get asked if they would like this assessment. It's fine to say no, but certainly is there if they want it. And we assess for things like housing, food, nutrition, transportation, all of the things that encompass somebody's life to be successful in the roles that they need to be successful within. And so we ask that when they join our pregnancy program, and then we ask it again postpartum to ensure that we know that when you have a baby or if you take a baby home with you, that your needs may have changed. And so ensuring that you have the right resources available to you for you to be successful as you have that new baby as well. And the digital health navigators that we've been talking about align all of these resources. They are embedded within our communities. They are at community-based organizations. They are at health fairs, community events, things of that nature, to really understand the lay of the land within their community, what's available to patients in their communities, and then align them to those resources accordingly to get the help and support that they need. So we're really thankful for that group of people and how they're spread within the state of Illinois to ensure that we are aware of the resources and the opportunities within those communities that we serve. This is a little snapshot of the data. So we went live with this program in August 15th of 2022. And this data is pulled through April 1st. So about 7.5 months, 8 months of our journey. And I could share with you even more data from what we've had experienced in those first couple months now that it's been a few weeks post that. But within those first 8 months, we served over 1,300 women within our pregnancy and postpartum support program. And today we sit around 1,500 women that we have been supported now about 4 to 6 weeks later. Within those 1,300 women, we had nearly 11,000 chat correspondents. So this is all messages back and forth with patients within the app of questions that they're asking, symptoms that they're experiencing, anxieties or fears that they may have, to really support them in a new way. And they're very engaged in the chat aspect. We have, our team has resolved over 1,100 alerts. So those check-in questions that patients get throughout their pregnancy journey, those can bubble up to us as alerts. And that means that what that patient has inputted is very concerning and we need to act quick. And so some examples of this may be the depression screening or a blood pressure. If a patient has a high blood pressure that's concerning, it red alerts our team and we call that patient quickly, triage them and do a virtual visit with a provider or send them to the right level of care to get the care that they need. And then through those first 8 months, we do have our providers who are also on 24/7, 365 and saw over 400 patients within that time period to continue to support them in their pregnancy journey. 81% of patients who consent to the program are engaged. This has actually been so much higher even in the recent weeks. I think when we started the program, it was a little slow, so our data is continually normalizing, but this is meaning that patients who enrolled into our program, who said yes to our program, created their account, activated it, are engaging with our nurses and our clinical team throughout their journey. And I would say here in the last 4 weeks, our engagement rate week over week averages closer to 95 to 97%. And I think that really speaks to, first of all, maybe the need of additional education and resources that these women are having or are experiencing. And the second is that, some research shows that pregnant women go to the internet for resources. They want to find their information easily accessible to them. And so that age group or that population is often digitally inclined, and this is how they want healthcare. This is how they want to know their source of truth. And so being able to provide that source of truth of education or what they're experiencing is normal or not normal has been a really great place to be. And then 86% of patients who have enrolled in our program say yes to that social determinants of health assessment. So when we enroll them into the program or when we check on them postpartum, say, yep, I think I need resources. And then 36% of them actually complete the process end to end and get the resources, most likely from a community-based organization that is needed. When we look at this data specifically in comparison to our other digital healthcare programs and really some other averages nationally, this is a really high percentage rate of completion. This 36% for our pregnancy program compared to some of our other digital programs is just really high and shows the need that women are experiencing and the follow through that they're having on actually getting their needs met, which is great to see. The next thing I'll share with you is a couple of patient comments. And so kind of like we talked about in the beginning, patient feedback is so important to us. We ask a lot of patient satisfaction questions throughout their journey to ensure that we are meeting their needs, especially because we're new and we are always open to making changes or tweaks to continue to enhance the program. We have a Net Promoter Score in the 90s for this program, which is great. And so here is just some anonymous comments that we have gotten from patients. And so I'll just read a couple of them to you. I'm always able to get the help and have questions answered, even at 2:30 in the morning when I'm at work. I work midnights as a CNA, and those are the times I have the most questions about different things that I experience. And I think this is true for so many, whether they work that night shift or you're just up in the night because you're pregnant and you have those questions, anxieties, fears. Having a nurse that's readily available that you can text at any minute and get answers within minutes really brings so much peace and so much comfort to patients, and having that opportunity to connect with a clinical person and get your need met is great. It also has given us the opportunity to really connect with women and build relationships. Because we care for them for so long, almost a year, when you think about that 8 weeks of pregnancy through 6 weeks postpartum, we connect relationships and we get to know them and they get to know us because it's constant engagement and messaging, phone calls, video chats back and forth with this population. The other one that I'll call out is I like that someone called and asked if I would like to join this. It was very nice because I will be going about 10 weeks without an appointment. So if I have questions, I feel very comfortable with this app and be able to ask questions if need be. And so in some areas, we do see maternity deserts and that patients are not getting into their in-person OB support for maybe many weeks after they become pregnant. And so still being able to enroll them at 8 weeks of pregnancy and answer some of their questions, do some virtual visits with our providers if needed, has been a great tool to meet the needs of those who can't get to in-person care or because of access issues can't get in to see a provider until that solution is met. And then certainly if somebody enrolls into our program and does not have an OB, we ensure that we align that and get their visits scheduled and started so they can get the care that they need. And next I'll share a story with you, and really we could stay here all day and share stories about outcomes that we have seen just in the short time that this program has gone live. But I think one that stands out to me and is really truly impactful is a woman who had chronic migraines pre-pregnancy and had her baby, and within the postpartum journey had a migraine again. And because she had established that relationship with our nursing team, just casually said, I have a migraine, I'm not feeling my best today, but I think I'm doing okay. Well, that nurse went ahead and called her to see how she was really doing, had her take her blood pressure, and her blood pressure was indeed very, very high, and she needed IV antihypertensives to get that under control. And so had we not had that opportunity to connect with her or give that resource to just say, you know, I think I'm okay, but I don't really know, something that was perfectly normal, what she thought was perfectly normal was not. And so just really goes to show the value of having that 24/7 access point, establishing a relationship with a care team that you feel comfortable with to share that with, has been really great and really important throughout this journey. And then before we get to any questions, if we have some, the things that I'll share with you is some lessons learned. And so the first one is our postpartum loop expansion. When we started on this journey, we had said when we built our program that we will serve patients through 4 weeks postpartum. And really quickly, we learned that that wasn't okay, or that wasn't enough. We had several women within kind of that 3 to 4 week postpartum timeframe that would message in the loop or ask or answer our anxiety and depression screening and say, my mental health is not okay. I need help before my mental health gets worse. I'm suicidal. I am homicidal, things of that nature. And so we took a step back and just really looked at the situation to understand that most women have their postpartum follow-up visit at 6 weeks postpartum. And so we wanted to ensure that we were supporting those women until they get to that 6-week postpartum visit to continue that in-person care and resources as needed. And so that has just been a great expansion. 2 weeks can make all the difference in some cases. And so we're glad that we can support women a few weeks longer within their postpartum journey. And then kind of on that same note, some staff simulations on suicide. And so I unfortunately can count several times that this truly has happened to patients in our program. And our nurses, we wanted to ensure that our nurses felt confident in the care that they were giving to patients and the resources that they were getting them as they're escalating them to that in-person care or to that next level of care to ensure that they're getting what they need. And so our education team, we have a innovation center that is just, it's a great place, learning opportunities, it's full of simulations, but within that space, they can also do virtual simulations. And so our nurses get on the phone with standardized participants who say that they are suicidal. And the nurse runs through it just like they had a live patient on the phone with their documentation within our health system and the conversation that they would have with that patient. And this really has proven to be successful. We had a nurse who had done that simulation and then many weeks to months later had a suicidal patient. And she reached out to our educator who helped develop the sim and run the simulations and said, I felt so much more confident, I think, than I would have felt if I hadn't had that sim, because I knew exactly what I was going to say to that patient. I knew exactly who I was going to call, what I was going to document, all of those things to help that call go the best that it could to get that patient right to where they needed to be in the right time. And so we have actually integrated quite a few simulations, not just suicide, but of some of the hot topics that don't occur on the daily basis, but happen often enough that we want to ensure that we feel really comfortable in doing. And then group education sessions. We talked about this previously, but this was not a part of the original plan for this program. Not saying that it was out of the picture, it's just not something that we had initially planned for. And so as we got into it and we're just really hearing the needs of the patients that we were serving and just the questions that they were having and what they were experiencing, started to embed some of those group education sessions to ensure that we were meeting the learning styles of all patients, or they had extra opportunities to learn about some of those topics, to relate to other women who are in the same journey of life that they are on, has been wonderful. And then lastly, what the future holds for us is a pregnancy loss loop. We have had quite a few women within our program that have lost their baby. And so we do, at the time of the loss, we take them out of our program so they don't get that education or those check-in questions that are on pregnancy. And we do check in on them for the weeks to come. But having a care plan in place that gives them education about what they might be experiencing through that pregnancy loss, or checking questions on how they're doing, or checking in on anxiety and depression. We just want to ensure that we have a well-rounded solution for women in this space, as we know that it happens more often, of course, than we would like it to. So we want to be set up for success in thinking about and caring for all pieces of pregnancy and postpartum for this population. Well, that is really all about our program. So Melinda and I really appreciate you listening and having some time with us. I'm just going to check here to see if we have some questions. Okay. The first question here is, are there extra supports for people who may not have regular access to the internet or people with low digital literacy? Yes, absolutely. Actually, if a patient does not have a smart device like a phone, a tablet, a computer, internet, we give our patients a tablet with cell service on it so they can engage with us in that way. I'm assuming that provider teams had to agree and approve on content that's provided to patients. How did you work to get the care plans and decision trees used by the 24/7 clinical teams approved by providers? So within this space, I would share that we have care plans that are created within a group that has physicians, nurses, advanced practice providers that's building all of that content, but we have the opportunity to completely customize that content in what we share with patients. And then once we get those care plans, we customize them. But then Melinda, I don't know if you want to speak to just kind of how our providers then review that content too, and give feedback.
Yeah, thank you. Can you hear me now?
Yes,
okay.
We can.
Somehow when I had the screen up, I got muted and didn't have an unmute button. So we do within our healthcare system, we have care guidance teams related to our service lines. And so one of the midwives that's deeply embedded in this program also sits on that care guidance team. And so we look at that related to our other clinical standards across our healthcare system and make sure that those are aligned. And then we also bring those back through our on-call quality structure. So those are always reviewed to make sure that they're in line, as well as the national review that happens with some of the vendor work. There are groups of clinicians that work on those from a national standpoint too, that has a group of physicians, APPs, as well as nurses involved in those as well. So I feel, there's the national work that happens, and then there's the work that we do within OSF Healthcare. I think one really important thing, this is what I was trying to tag on earlier to say, is that this can be difficult work sometimes when you're embedding it in your current healthcare system, because there is, if you haven't done a model like this in the past, sometimes the change management around the clinician beliefs around a program like this can be difficult to manage. And we still have some of that we manage today. I think the important piece that we constantly are trying to really instill in our clinicians is that if you have a woman who is waiting 10 days, 20 days, 35 days to get in for in-person care, we really are doing her a disservice when we can be offering some of this on the front end, connecting to her, making that relationship with her, providing her a service where she can get education and connection to our clinical team. And then we certainly still want her to continue those visits with in-person care. So this is adjunct to that. And this has been, well published and articulated in some other healthcare systems as well, but it definitely is, newer in many of the markets we serve. But I just think as we look at the number of women and the number of OB areas that are closing, we have to think about these innovative models of care to really offer to them to ensure that they're not only getting the care that they need, we're protecting them, we're protecting their baby, and giving them the education that they need through this layered clinical approach.
Thanks, Melinda. All right, the next question here is there a safety net to catch trans people who are having babies? I'm wondering if example, if somebody identifies as male, change their gender marked legally to male and becomes pregnant, will they be supported by this service? Absolutely. We have had some individuals who are transgender, and so we just ensure that their sex at birth is documented and the sex that they identify as now is documented, so we are caring for them in the appropriate way. And then for data-driven outreach, what data are you using to identify members who are pregnant? So within our medical record, if they have a pregnancy episode, amongst a couple other ways to document if a patient is pregnant, that triggers on our reports of patients who are pregnant, and so we call them according to that. Let's see here. All right. Could you comment on the equity considerations in the program? On the one hand, digital health programs like this seems they can really break down barriers to care. But on the other hand, by relying on some basic digital literacy skills, it seems like it could also be creating some barriers. Melinda, do you want to take that one?
Sure. I think that this is definitely something that we're always cognizant of. And I think that when you think about the younger age generation of women now too, most of them are fairly literate as far as using a phone. I mean, using a cell phone, a text message, they're able to do that. I would say even some of the belief bias that we had around some of our elderly patients not wanting to do that, we've really been able to prove that that's not the case at all, that sometimes they're our best texters and they become really appreciate the communication stream. So I think one of the key things about these programs is our digital health workers, and those they're part of that community. They understand that community. They are able to connect with those patients. And if we find that they have some of those barriers, we can help to educate them to do that. If not, we can definitely connect them to the resources, whether it be in-person care or a community resource of that nature to help meet those needs.
Thanks, Melinda. Another question we got is, do you offer cribs? While we don't offer cribs directly, those digital health navigators that we've been talking a lot do know about community resources that do. An example of this here in the Peoria area is our coroner's office provides pack and plays to any patient who does not have a safe space for their child to sleep. And so just kind of another part of that digital health navigator layer that aligns that social determinants of health. They know about those resources to get items like that to patients that may need it. The next question is, how is the program funded? So this program, again, is in collaboration with the state of Illinois, with those other 4 federally qualified healthcare centers that have provided the funding and help with the oversight of the Medicaid Innovation Collaborative. I don't know, Melinda, if there's anything else you want to share on that end.
Yeah, so just a little bit of background on the Medicaid Innovation Collaborative. I believe it was around 2021 that the state of Illinois, in regards to Medicaid, really put a RFP out for programs that could be developed to meet different innovative needs or transforming care for Medicaid patients. And so part of that work, one of the pillars, the quality pillars that were required was around maternal care, just because we know that this is a gap not only in our state, but really across the country. And so we wrote to this proposal and proposed some of the remote patient monitoring work. Included in this is our prenatal work to really try to help to grow and scale these programs to first serve the Medicaid patients, but then continue to expand that to other individuals in the future. So we did partner with our FQHCs who have a lot of intersection with patients that may have some care gaps along the way, or may have transportation issues or food and shelter issues that we can assist with as well. So I always think about this as a connection point between a large healthcare system and really the community and all of the resources around them that have to come together to care for, specifically for this program, for Medicaid patients in a new and different way, because many times there may be trust issues with healthcare systems. There may be, as mentioned, transportation or food insecurity things. And so this is a partnership between the healthcare organization and the community to meet these needs. It's not one group really all on its own, because we found that we've had that methodology for many years and we're not reaching these patients. And so what would happen is these women would come into our emergency room or our birthing units and deliver their babies, and sometimes not have the best outcome either for the mom or the baby. And we recognize that's not what we want, and we certainly don't want that in our community. So trying to get on the front end of that to really help was our goal with this program.
Perfect. Thank you. There is a couple of questions within here about Ohio, and just to clarify that this is with the state of Illinois, not with Ohio. But there was a question about, do the participants of this enrolled program deliver at, it's at an Ohio facility, I believe. But just to share that, because this program truly is for the state of Illinois as a whole, and any Medicaid patient within that area, they do not have to deliver at an OSF facility. It is up to the patient's choice. The data does not show that our patients deliver. We don't have delivery facilities in the whole state of Illinois. And so just really trying to gap the needs. It's just that OSF is providing the service, but certainly giving that patient the freedom, the choice to deliver at any facility that they so choose. Have folks ever requested referral for termination? I think that we have maybe had that once within the pregnancy program, and within our healthcare space would have to give written information on how they could access such services. Are partners and or family members allowed to attend the digital appointments with patients and clients? Yes, they are. I would say probably more times than not. We often meet a family member on a digital visit, just given what's going on in the home. Maybe they're a single parent and have other children at home that they're caring for. So while there may be others on the video call, certainly focus in on talking to that patient specifically, getting their needs met, and caring for them well. Do you need to ask permission for a social determinants of health assessment, and would that be a good routine assessment? Melinda, do you want to share a little bit about kind of our social determinants of health journey and how we really integrate that into all of our programs, maybe not just in this space?
Yeah, so, OSF has been on, as Kara commented, a journey really around social determinants of health, understanding that not only for Medicaid patients, but for all of our patients really that we serve, there may be things that they are lacking. Again, it could be food insecurity, it could be transportation challenges that may be influencing their chronic disease. And I think that's been written up in the literature for us to understand as well. So one of the things that we've done over the past several years is try to put social determinants of health even in our primary care practices. And then when we started our on-call programs, we really embedded social determinants of health as a core piece of every assessment that we want to do on our patients, because it gives us valuable information about what could be influencing their care that sometimes they may not even think about. So it may not be front and center in their mind that how it's influencing their health, or it may be and they don't know the community resources to connect to. So we've really made a dedicated effort across our healthcare system, and for sure within OSF On-Call with all of our different programs, to make sure that we're assessing for social determinants of health, making sure that we're connected to our community resources. Because again, just like even in leadership, when you ask people for the information and they give it to you, but you don't act on it, that's sometimes worse than, not asking at all. So we've really made a dedicated effort to, we're going to ask you about social determinants of health, and then we're actually going to work with you to fix those gaps if they're identified. And we work really hard with our community members to do that.
Thanks, Melinda. There was kind of another question related that said, I just wondering about the definition of the complete statistic of the SDOH. And that means that when we ask that patient, do you want a social determinants of health assessment? And they say yes. Then we say, do you want it by phone, text, or email? Well, you can imagine that the rate of text and email is very high as far as how they want to receive that questionnaire. And so when we talk about complete, first of all, they have to say yes to wanting that assessment. Second, they have to actually complete it. Click on that link in that text message, click on that link in that email address, and identify the needs that they have. And that's where we see the biggest gap or break within the system. And we send it a couple of times. We don't want to pester the patient, but certainly send it a variety of times to ensure that they have the opportunity to complete the assessment. And then next, they get a phone call from those digital health navigators to align the resources to them. And then the last step then is actually completing getting that resource. So there's really a lot of factors into what that complete means. But again, the biggest challenge that we see with that process is the patient truly completing that questionnaire. Is there any plan to scale this across the United States and include other states? If you asked any member of my team, they would say, we would love to do that. They want to care for every pregnant woman, every baby across the United States. Of course, it's a licensure thing, right? Well, first, we're under this Medicaid Innovation Collaborative to serve the state of Illinois. That's where we're starting. And so then, like Melinda said, hopefully expanding to other populations. And then who knows what the future could hold. Certainly would be a passion within some members within my team.
Yeah, and I think, there's certainly opportunity for that. And we're using this time of this program to really learn from it and be agile and make changes as we need to help it grow and build our leadership team and the skills and competencies, and also build the trust of our patients, the physicians, the APPs, our nurses that work within our healthcare system to say, this does work, this is making a difference. And some of the work that we're doing around this Medicaid Innovation Collaborative is true research. So this is part of an IRB submitted program, so we can look at data and say, we are making a difference, because we certainly don't want to invest dollars somewhere that we feel like we're not getting the patient outcomes that we are desiring, or improving the health of women and babies in particular to this program.
Thanks, Linda. And then I think the last question that we have here is, what is the schedule to cycle the virtual weekly education groups every 5 weeks? So we actually host like the same content month over month. So like we do normal signs in pregnancy that first week of every month. We do labor the second week of every month. We do infant care the third week of every month, and then breastfeeding the fourth. So while they're in our program for almost a year, they have multiple opportunities to join those same topics. If they want to join again, maybe they didn't get all their questions answered or whatever it may be, just to identify what those needs are. All right. Well, I think that's all our questions. Again, thank you so much for joining us this afternoon. It's really an honor to share about our program and the opportunity that we have to transform the way that we care for women within our state who are pregnant and have Medicaid.
Yeah, I would just echo that, Kara. Really proud of this work and really proud of this leadership team that carries out this work each and every day for the betterment of our patients and our babies out there. So thank you for taking the time to share with us. We're happy to answer any other questions that you have or that would come your way. And sorry about my technological challenge today a little bit.